when life is at stake and every second matters. A 1% error is never acceptable. In HealthCore, our mission is to make our hospitals and clinics safe for patients and health workers, providing excellent quality of care, even at the most critical and challenging times. We educate and train our healthcare professionals with practices benchmarked on global standards through our recognized international experts, faculty, and consultants, endorsed by government bodies and medical societies. HealthCore Academy, your reliable partner for world-class healthcare delivery and patient safety.
Ladies and gentlemen, our program director and moderator for this online forum, the founder and president of HealthCore and Health, Retirement, and Tourism Alliance of the Philippines, the patient safety ambassador for the ASEAN region, Professor Joy Socao, alumno.
Good afternoon to all our participants from Luzon, Visayas, and Mindanao, and all over the world, as we have various countries like Malaysia, US, Europe, India, and other parts of the world. Right now, we are being aired live over Zoom and also on Facebook. This video is also being recorded for later viewing in YouTube and in HealthCore's website. Today's online forum is actually a substitute to what we earlier planned for our first virtual conference, which is on the universal or the implementation of the universal healthcare. But we realized that with COVID-19 continuously creating havoc in our country, even as we end 2020, the hospitals and their allied healthcare providers and suppliers are in a quandary as to what lies ahead for them in 2021. Will they be able to cope with the growing demands of patients with still over 1,000 COVID cases being added every day, the endemic shortage of health workers even before the pandemic, the maldistribution of hospitals across the country, wherein we have an average of about 1 hospital bed for every 1,000 population, which is far below the WHO recommendation for underdeveloped countries, which is 3 for every 1,000 population. In real terms, there are only 2,000 hospitals catering to 110 million Filipinos all over the country, and out of these, only 1,000 are private hospitals. Most of them, if not all, are currently in great financial distress due to the earlier chronic problems that I have already mentioned, and the addition of COVID-19's unique demands that entail a great deal of resources, resulting to low admission rates because patients and even health workers are afraid to catch the virus in the hospitals. And of course, the ongoing unresolved issue of non-reimbursement by PhilHealth to many of our hospitals that is reported to have reached already about 13 billion pesos. So today we are going to talk about the business of hospitals, or the hospital business and its allied services. I believe this is something that was not talked about in many of the business forums because they feel that the hospital business does not operate like any other business enterprise. Most of the time, the hospitals are viewed as a social enterprise that is not supposed to make money from the sick people. And so that has placed all of them at the risk of financial instability when they are confronted by risks and hazards that were never foreseen nor considered to happen. The rising tide economics highlights the challenges that all boats must rise above the waves, with nobody left behind. I believe we're now reaching the trough of these waves, and the only way to go is up, above the waves, and not to be swallowed into the pit of the ocean. We have received over 200 questions from our participants. At this point, I think it's about 400 already, which we have provided to our panelists in advance for them to hopefully be able to answer during this forum. All of them given 15 minutes to present, and including a Q&A later on. So to start off, I will not keep you waiting, of course. For our first panelist, we have the president of the Philippine Hospital Association to talk about the economic challenges in operating a hospital during pandemic, which will lay down the foundation of our discussion this afternoon. By the way, all the profiles of our speakers have been uploaded on the website www.health-core.academy in order for us to save time, because reading their CVs will probably take me 2 to 3 minutes because these people are highly credentialed and they have so many achievements under their belt. I would like to present to you the president of Philippine Hospital Association, Dr. Jaime Almora.
Good afternoon, everyone. I am Dr. Jaime Almora, the president of the Philippine Hospital Association, an organization of about 1,907 hospitals, both government and private. 60% of them are private hospital and 40% are government hospital. I am happy to meet you all in this virtual forum to finally meet the big names, the eminent people of commerce and industry, our officers of BCCI and our banker. Thank you, Ms. Joyce Alomno, the President and CEO of HealthCore, for this opportunity to talk on the topic economic challenges for hospitals during the pandemic. I would like also to greet Ma'am Vergeri, Yosek Vergeri, and Sir Obed. The hospitals have experienced significant economic downturn because of the pandemic. Yes, all the hospitals have experienced and is experiencing significant decrease in economic activity, despite the fact that not all hospitals ended up admitting COVID cases, and despite the fact that not all places in the country have been significantly affected by COVID virus. Our government, through the IATF, was in fact successful in immediately locking down the virus in Manila that prevented it to spread widely to the provinces. It was only until 4 months later when the economic crunch set in, forcing the government to loosen the quarantine and allowed people, the locally stranded individuals, to go home to their provinces. It was only then that the virus started spreading to some places in the country. That 4 months of a strict lockdown was crucial in allowing the local governments and the hospitals to organize and prepare for the arrival of the virus. When the virus finally arrived, in the different populated centers of the country, the identified COVID centers, hospitals, mostly government hospitals, level 2 and level 3, were already ready to accept them. The smaller hospitals, the infirmaries and level 1 hospitals, and some level 2 private hospitals did not have to admit COVID cases. They only triaged them, and the positive cases were referred to the quarantine in the LGU quarantine facilities. Nevertheless, there was and there is 50% to 60% decrease in the economic performance of all the hospitals, regardless whether they have admitted or not. We have in the next slide please. We have in the next slide the indicators of this economic downturn. We have a decrease in the bed occupancy rate, a decrease in the outpatient census, a decrease in the laboratory procedures, decrease in the radiologic procedures, and decrease in the monthly revenues. Next slide, please. Let us start with a decrease in bed occupancy rate. You can see in this bar graph, the bed occupancy rate starting from January 2019 up to October 2020. The one in blue is that of 2019 and yellow is that of 2018. I would like to invite your attention to that period after the declaration of the lockdown from April to October of this year. You would notice that there is a significant decrease in the performance compared to that same period of 2019. Also, something here in this graph is also quite interesting. If you would look at January, February, and March, which was before the lockdown, the performance is still much lower than the performance of the same period in January, February, and March of 2019. So there is something that happened here which caused low admissions. This is not due to the virus because people are still free to go around, to move around. But in this period, if you will recall, this is already the time when the effect of the rice tariffication law was set in. This data is from a level 1 private hospital, 50-bed capacity in a rice-producing and agriculture-dependent small city in northern Luzon. So from here, you could see an almost 50% decline in the bed occupancy rate. Next slide, please. And these are the causes of the decline in the bed occupancy rate. There is fear of going to the hospital. There is restriction of movement and travel. There is lack of public transportation. Doctors are not in their clinics. There is a general decrease in the income of the population. In most areas, those in different industries, the workers are not able to go to work, and so they have a decrease in income. And in the rice-producing area and agricultural areas in the country, there is also a decrease in their income despite their harvest because of the effect of the rice tariffication law, where there is a decrease in there is no quantitative restriction in the importation of rice, creating glut, and also because of fear of spending. Next slide, please. Okay, here are the causes in the decrease in outpatient census. The decrease in the outpatient is the same reason as the decrease in the bed occupancy rate, the inpatients. There is a general decrease in the infectious diseases like respiratory infection, flu, and dengue. If you look at the graph, the previous graph, this is an unintended beneficial effect of the use of face masks and physical distancing. The face mask and physical distancing prevent these communicable diseases, the respiratory infection, the flu, and the dengue, from being transmitted. And so we have low cases, and that contributes to the decrease in the outpatient census. There are fewer clinics that are open as doctors prefer to do teleconsultation. However, there is an increasing cases of lifestyle diseases, which is related to the sedentary living of people in the quarantine, or people observing isolation. These are hypertension, stroke, diabetes, and obesity. Next slide, please. Okay, there is also a decrease in laboratory procedure. So the same thing that happened to the inpatient, outpatient, there are fewer patients, so there are fewer procedures. The rapid antibody and later the rapid antigen test that came out after few months, in some degree compensated for the decrease in the laboratory procedures. Also, there is an increase in the RT-PCR laboratories. Some tertiary level hospitals investing in putting up RT-PCR testing centers. Next slide, please. Next slide. And another indicator is the decrease in radiologic procedure. Another unintended beneficial effect is the low accident rate, which is one of the most common causes of radiologic procedures, accidents, bone fractures, the limitation in the movement of the people. There are fewer accidents. Next slide, please. And there is a decrease in the monthly revenues of the hospitals. The income has plummeted below 50% after the start of the pandemic. This is seen across all the revenue generating centers of the hospitals except the hemodialysis department. There is also a decrease in about 25% of hospital bed occupancy rate starting in October 2019 until the start of the pandemic. And this is because, like I said a while ago, the decrease in the purchasing power of the people, because this data was from agriculture-dependent hospital, and it is due to the rice tariffication law. And lately, the farmers in most of the country is agriculture in nature, agriculture-dependent, I should say. And most of the farmers lately receive a triple whammy. First was the loss of income from the effect of the rice tariffication law, which started in October 2019. This was followed by a loss of other job opportunities due to the pandemic starting in March and April of this year. And lately, there is loss of their crops to Typhoon Rolly, Quinta, and Ulysses because of the terrible floods in almost the whole of Luzon. Next slide, please. While there was decrease in the revenues of the hospital, there is increase in the expenses because of the structural conversion and construction to provide for triage area, outpatient holding rooms, inpatient isolation rooms, intensive care units, and physical barriers, provision of medical barriers in preparation of and or to receive COVID-19 cases. Regardless whether the hospital has admitted or not, all of them has to provide for these physical facilities. There is also an increase in the purchase of expensive PPE, especially at the outset when the PPE has gone as high as 1,000% higher than the usual price. And also, the hospital has to accommodate their key personnel because there is quarantine and they need to have a travel pass. So and there is no public transportation. We have to be accommodated in the hospital facilities. So there is an increase for their meals and lodging. And also, for those who have to go home, the hospital has to provide them transportation and be shuttled to their houses. And there is an increase in the expenses for hygiene and sanitation, the alcohol and the antiseptic solutions to clean the hospital facilities. And there is an increase in the procurement of medicines, reagents, and other hospital supplies because we have to increase our stock in preparation for a possible surge of patients, and that may incapacitate the hospital. Next slide, please. Okay, there are aggravating problems uh, to all these things, and one of them is the decrease in manpower, especially the nurses. This is an interesting and quite extensive topic, so in the interest of time, we'll just pass over it and maybe come back to it in the question and answer time. And there is deficient supply of personal protective equipment and the opportunistic skyrocketing of prices. And of course, we know the corruption scandal in PhilHealth. There is a restriction in mobility, lack of doctors to receive referrals, lack of suppliers for hospital supplies. There is deficient COVID-19 testing centers. Next slide, please. And there is the unclear pathophysiology of the disease at the outset, which makes diagnosis and treatment a guessing game. And there's no clear therapeutic intervention. Politicalization of the pandemic, mostly in the LGU, they are prone to engage in visually noticeable intervention rather than those that would actually help in the prevention of the spread of the disease. There's general economic downturn in all the industries. And there is that wrongful accusation about the IRM, or the interim reimbursement mechanism, and the case rates, and the accusations of hospitals as causes of fraud in PhilHealth, in failure of PhilHealth to pay reimbursement claims on time. And there are arbitrary denial of reimbursement claims by PhilHealth. Next slide, please. The litany of all those problems is not complete without mentioning the current and future threats to the hospital. And these are the way I see it. Some of the provisions of the universal health care are impossible, ambitious, and ambiguous. There is also an oppressive provision in the universal health care, such as the no balance billing for private hospital admissions, where basically it is not in academic. The 10% limit for no balance billing is not in academic, because if a patient would request for is an AO being drafted in DOH, providing for a fixed copay for non-basic accommodation in private hospitals, despite the absence of such provision in the Universal Healthcare Law. The Universal Healthcare Law provides only that those who are admitted in the non-basic accommodation, meaning the private rooms, may pay for may have a copay, may be charged for a copay. This will adversely affect the quality of healthcare provided to patients, despite the willingness of patients to pay for the best and for all possible care. Another threat is the proposed amendment of the procedures, rules and administrative cases. Procedures and rules on administrative cases, which defines the quasi-judicial power of PhilHealth. The amendment proposed to authorize the PhilHealth Regional Office to issue preventive suspension and deny accreditation to healthcare institutions, even without due process and for reasons such as previous conviction of violation or pending investigation of a case. For a mere trivial violation, a hospital may be suspended, and this means death sentence to a hospital if they are suspended for quite a time, like, for example, 4 months and above, and or more. And the access of patients will be affected. The Universal Healthcare Law provides, the purpose of the Universal Healthcare Law is to provide accessible, affordable, and quality care. So if we suspend hospitals, then the community will suffer. And number 6 is the problem with the quasi-judicial power of PhilHealth, where in many cases this is being misused and abused against the hospitals. So those are the future threats of the hospitals. That ends my presentation. Thank you so much.
Thank you so much, Dr. Almora. We have actually already received several questions for you, and we will receive all of them during the open forum. And it was quite interesting to note that agriculture and healthcare are too much intertwined when it comes to economic impact. We are going to have Dr. Almora again for the open forum later on today. But before we proceed, I would like to inform everyone that this is being recorded and it will also be shown on YouTube and our HealthCore website during the week. So you will not be able to miss any part. And at the same time, all presentation slides will be uploaded on the HealthCore Academy website. Before we proceed, I would like to acknowledge the presence of some very important people on the floor. They're not going to speak in this forum, but they have taken part and they're participating. But they may be able to react or comment later on during our open forum. And perhaps you can also send your questions to them through our chat box, and probably they will be kind enough to answer you. Firstly, we would like to acknowledge the presence of one of HealthCore's advisors, the chairman of Joint Commission International for 2021 to 2023, and the present chairman of the Ramsay Sime Darby Healthcare Group. We are happy also to have with us on the floor from Malaysia, Dr. Jacob Thomas. Good afternoon, Dr. Jacob. Thank you for being here today. Also, we would like to acknowledge the Special Advisor to the National Task Force for COVID-19, former Undersecretary of Health and the present Executive Vice President of the University of the Philippines, Dr. Ted Herbosa. We also would like to acknowledge one of HealthCore's advisors from India, the Secretary General of the Association of Healthcare Providers in India, formerly CEO of NABH, Dr. Girdhar Gyani. Thank you for being here, Dr. Gyani. The next HealthCore advisor is also with us today, the Lady of Sports and Wellness, also one of the HealthCore's advisors and the former Undersecretary of Tourism, Ms. Cynthia Carrion. Thank you, Ms. Cynthia, for being with us today. From the United States, but presently enjoying Macedonia, the former Chief Strategist of Bumrang Red Hospital in Thailand, and also one of HealthCore's advisors, Mr. David Busher. Finally, we would like to acknowledge one of the pillars in the field of geriatrics in the Philippines, another HealthCore advisor, Dr. Miguel Ramos. And later on today, you will also hear one of our HealthCore's advisors, Governor Obet Pagdanganan. So the introduction, I will reserve that for later. So thank you all for being with us today. For our next panelist, we have invited the woman of the hour to present to us what are the DOH regulations that will affect our hospitals during and post-pandemic. What are the government's priorities in 2021 that will address the needs of our hospitals, increase the capacity and augment their resources during and post-pandemic? What are the projects in the pipeline of the Department of Health? Another question that we would like to answer is how can the private sector partner with the Department of Health? Ladies and gentlemen, it is my honor to present to you. This woman is very busy, the woman of the hour, the Department of Health, Undersecretary Maria Rosario Vergeire.
Thank you very much, Professor Joyce. Good afternoon to all of you. Let me just recognize all of my co-panelists. And of course, we have our friend Dr. Almora. Magandang hapon po. And Governor Pagdanganan, magandang hapon. And to all of you, good afternoon. We like to thank the organizers for inviting the Department of Health into this forum. So for today, I will be presenting the DOH regulatory measures that affect our hospitals in this time of COVID-19 pandemic, as well as the ways forward in addressing the needs of our hospitals to increase their capacity and to augment their resources. But before I zero in on all of this, I would just like to provide briefly updates on our COVID-19 situation. Next slide, please. As of November 18, we have a total of 412,474 cases of COVID-19 in the country. 90.92%, which is more than, for now, is our recovered cases, where this is translated into 374,666, while 1.93% would be our case fatality rate. 7.15%, on the other hand, are our active cases for now. So when we look at these slides, we have the disaggregation of our active cases as to the classification of their illness. So most of those that are active would comprise about 91 to 92% are mild and asymptomatic cases. Next slide, please. Critical to responding against this pandemic are these three strategies, which are isolation, testing, and treatment. For isolation, we now have a total of 11,374 isolation facilities all over the country, wherein we have this total bed capacity of 168,640. And currently, our occupancy rate is at 28.5%. So we still have about 72% beds which can be where we can accommodate patients which will have the requirement to be isolated because of COVID-19 symptoms. As for testing, we only started with one laboratory in February. Now we have 168 laboratories. We have 84 private laboratories and 82 public laboratories for COVID-19. We would find the disaggregation of these different laboratories across the different big regions of the country, and our cumulative number of tests that has been conducted as of November 18 is already at 5.3 million. Our positivity rate at 9.3 million when we do this cumulative computation. But when we estimate it or compute it based on the daily number of tests conducted, we are ranging from 5 to 6% as of this time. Our 7-day moving average for the number of tests conducted is at 29,128 tests being done every day in the country. As for treatment, we have our temporary treatment and monitoring facilities where we have this total bed capacity of 21,986, where we have a 39% occupancy rate. And this total bed capacity for hospitals, this is our hospitals where we have this occupancy rate of 39%. We have assigned different units in the hospitals which are to be dedicated for COVID, and these are our ward beds, our isolation beds, and our ICU beds. Later on, I will be discussing about the mandate of each hospital to allocate beds for COVID-19. So for now, if you may see, we are at around 53% critical care utilization. We are not in that danger zone anymore, and we are just in this warning zone. But of course, we would still like to decrease the utilization of beds for COVID-19. Next slide, please. At the outset of the pandemic, some hospitals have scaled down their operations, especially in hospitals where COVID-19 was increasing, and in hospitals where there were lack of PPEs and health human resources for health. Non-emergency services such as the outpatient clinics, elective procedures, and in some, even OB procedures, the obstetric procedures, were shut down. The Department of Health augmented hospitals, both public and private, with the health human resources for help needed. As of November 16, there are more than 1,300 nurses who are serving now in our different hospitals, and 393 doctors had been redeployed to hospitals with increasing cases of COVID-19. Next slide, please. The COVID-19 has redefined what normal is. Hence, there is a need to recalibrate reform strategies for hospitals and our other health facilities as we progressively realize the universal health care under the new normal. Pursuant to the Department of Health guidelines on the risk-based public health standards for COVID-19 mitigation, the DOH has been strictly implementing minimum public health standards and health safety protocols to prevent the transmission of COVID-19 and other infectious diseases. Hence, we have included in the guidelines that there should be no face-to-face interaction in our different offices, such as our Health Facilities and Services Regulatory Bureau and in our Food and Drug Administration. We did online transactions for applications or renewals for license to operate and certificates of accreditation through email. It was entertained, and in the light of the pandemic, some requirements for licensing were also waived, such as validated electronic health record system. For clinical laboratories, the National External Quality Assurance Scheme was also waived. For primary care facilities, the fees for the license to operate and the permit to construct were also waived. A unified licensing mechanism or a one-stop shop licensing system was also established to simplify the requirements and processes for initial, for renewal, and for variation of license to operate applications. With the passage of RA 11332, or the mandatory reporting of notifiable diseases and health events of public health concern, the DOH was mandated to conduct epidemiological investigation, case investigations, patient interviews, review of medical records and contact tracing, among others, for the control and containment of notifiable diseases like COVID-19. As such, hospitals and health facilities, whether public or private, that refuse, decline, or withhold patient information from the authorized DOH representatives, including non-cooperation and other prohibited acts, shall be penalized. Hospitals were also directed to submit relevant COVID-19 data, such as utilization rate of COVID-19 dedicated beds, infection and prevention control practice, and others through our Data Collect application. This allows the DOH to capture real-time information on the critical utilization rate in different areas in order to provide timely management and response as necessary. Next slide. The DOH also released an issuance on the COVID-19 referral hospitals that prioritized the management of confirmed COVID-19 cases. The DOH Centers for Health Development have assessed the capacity of the eligible hospitals in their respective regions to be designated as COVID referral hospitals based on service capability. The regional offices of DOH have designated COVID referral hospitals through the issuance of a regional order to all DOH hospitals. If the hospital to be designated as a COVID referral hospital is a non-DOH hospital, the perfection of a memorandum of agreement between the region and the entity that owns or manages the hospital shall be sufficient already. Lastly, RA 11494, or the Bayanihan to Recover as One Act, provided for the enforcement of bed capacity allocation dedicated for COVID-19 response across all government and private hospitals. With this, all health facilities shall implement the minimum health requirements for health setting. They shall also dedicate hospital beds such as isolation beds, ward beds, and ICU beds during surge of COVID-19 cases for mild with comorbidities, moderate, severe, and critical COVID-19 patients in all general hospitals in order to maintain the regional critical utilization rate at medium risk or below at least 30% of all current authorized bed capacity of government hospitals, or the number of beds corresponding to the need during the peak day critical care capacity in updated projections from a DOH-recognized epidemiologic projection model for COVID-19. At least 20% of all current authorized bed capacity of private hospitals and up to 30% during the surge of COVID-19 cases to accommodate and service COVID-19 patients. Next slide, please. Moving forward towards realizing health facility reforms under the new normal, the DOH laid down the Philippine Health Facility Development Plan of 2020 to 2040. The Philippines, relative to its income range, have poor health outcomes due to low access to healthcare. Hospital beds are scarce. The bed density of 1.2 per 1,000 population is comparable to the poorest countries in the world, such as the sub-Saharan Africa. The country is positioned to be an upper middle income country by 2021. Yet, there is a huge difference between our country and these upper middle income countries, which averages 4 beds per 1,000 population. While there was an increase in the number of private hospital beds in the past 10 years, the bed to population ratio has declined because of the slow growth of public beds and the rapid population growth. Many provinces have no available higher level of hospital care. 33 provinces and highly urbanized cities do not have a level 2 hospital. 3 regions, Region 4B, Caraga, and BARM, do not have a level 3 hospital. The first Philippine Health Facility Development Plan was developed and approved in principle by our President in 2017. With the passage of the Universal Healthcare Act, the plan was updated, focusing on investment needs to build resilient and modern health facilities. The Philippine Health Facility Development Plan has studied the health infrastructure need for the country to achieve universal health care. Pertinent to the realization of the plan is the fulfillment of other critical elements, namely the human resources for health plan, sustained predictable financing over a fixed period, and an increased investment for health from the private sector. Next slide, please. We have tried to address the scarcity of health facilities since the year 2009. We have identified problems with the current planning process and implementation for health facility investment. Health facility planning targets are ratio-based and are not based on the health burden and demand. Plans are based on requests. It do not take into account the gatekeeping mechanism of primary care facilities and do not include the private sector. Health human resources for health plans are often not aligned with the health facility plan. Moreover, financing has been unstable and there is limited public resources for both national and local government units. Our ASEAN neighbors, Thailand and Malaysia, spends 4 times more in health compared to us. The Health Facilities Enhancement Program also has a poor absorptive capacity. Next slide, please. So the proposed Health Facility Development Plan has targets that is based on the current and projected burden of disease and the need of the population. The plan now includes an allocation framework that promotes efficiency and equity. It is based on the service delivery model that is aligned with the Universal Healthcare Act. It calculated infrastructure requirements to build healthcare provider networks. In addition, the private sector's role is already included. The Philippine Health Facility Development Plan has estimated the demand for health facilities according to the burden of the disease and the resource stratified framework. Using the framework, probability trees and projections were done for 25 priority diseases. The probability tree were then validated with expert technical working groups. Afterwards, the need for health facilities were calculated and the current supply was gathered. For private primary care facility, it was only estimated. Gaps were determined by correlating the estimated need with the existing supply in the consideration of physical access for primary care facilities. Next slide, please. The 1.2 beds per 1,000 population is comparable to the poorest countries in sub-Saharan Africa, while upper middle income countries averages at 4 beds per 1,000. Based on the projected health needs of the population as to how many people are projected to be hospitalized, the country needs to double the number of beds from 1.2 to 2.7 per 1,000 population by 2040. The need for hospital beds by 2040 based on the demand model is around 2.6 per 1,000 population, disaggregated by levels 1 to 3 beds in our hospitals. The formation of the healthcare provider networks was considered in the projection of the need for hospital beds by 2025, as this is the direction of the universal healthcare. The increase for beds in level 1 hospitals should be prioritized because it has the largest gap at 237,480. Next slide, please. With a projected need, the share of the private sector was estimated depending on the existing private market penetration in each province or in each city. So we'll find in this slide, the yellow would be the private and the red would be the public sector. Next slide, please. The plan proposes a national allocation framework which objectively guides resource allocation for local government units based on the resources that they have, like presence of GIDA areas and level of household income. LGUs are categorized depending on the capacity and the calculated gap. To promote equity, a higher allocation is given to low capacity compared to high capacity areas, and high gaps compared to low gaps. Provinces and highly urbanized cities and independent component cities were divided into four: low capacity and high gap, low capacity and low gap, high capacity and high gap, and high capacity and low gap. To reduce the gaps in level 1 and 2 hospital beds, the government needs to spend 20 billion annually in the next 20 years. And this entails 100% allocation to provinces under categories 1 and 2, 50% allocation to category 3, and 25% allocation to category 4 provinces and highly urbanized cities and ICCs. To reduce the gaps in level 3 hospital beds in the next 20 years, the government needs to spend about 9 billion annually, and to reduce the gap in priority equipment in the next 5 years, the government needs to spend around 8 billion a year, which will be needed until 2040. This entails 100% allocation to category 1, 50% to category 2, and 25% to category 3 regions. Next slide, please. In coming up with the gaps, we accounted for the private sector, especially in high-capacity local governments. In order to encourage private entities to help in building health infrastructure, here are the strategies the country can employ. First, we can use tax exemptions and incentives such as the Board of Investment tax holidays and duty-free importation of equipment. Second, we can help create attractive financing scheme in PhilHealth reimbursements to promote equity in areas with high gap. And third, we can provide subsidies, financial grants, and non-financial assistance to encourage them to build priority infrastructure. Another example is allowing the market to cater to foreign patients such as medical tourism. The tax revenues can be earmarked for health. However, further studies should be done to determine the feasibility, equity, and long-term implications of this proposed venture. Next slide, please. Investments for government-run special facilities are critical to complement primary care and hospital-based general health services. Specialty centers for 16 specialties shall be established: cancer care, cardiovascular care, lung care, renal care and kidney transplant, brain and spine care, trauma care, burn care, orthopedic care, physical rehabilitation medicine, infectious diseases and tropical medicine, toxicology, mental health, geriatric care, neonatal care, dermatology, and eye care. Selected DOH hospitals shall be designated as national specialty centers, advanced comprehensive specialty centers, and basic comprehensive specialty centers for each of these specialties. Investment needs for infrastructure and equipment until 2025 totals 82 billion pesos. Upgrading and establishment of specialized laboratories, including the national, subnational, and regional reference laboratories, shall require a total of 1.1 billion pesos. And capital investment requirements for blood service facilities and drug abuse treatment and rehabilitation facilities in the national, subnational, and regional levels totals to 3.5 billion and 8.4 billion pesos respectively. Next slide, please. So this will be my last slide. From the insufficiency of available facilities, our vision is that facility planning takes into consideration proper distribution to cater to their catchment population and that physical access factors are considered. With the revitalized Philippine Health Facilities Development Plan for 2040, we look forward to its translation into effective provincial programming. We believe that we can bring to life our vision for universal healthcare by aligning all stakeholders within a single development plan for health facilities so that Filipinos will truly have quality healthcare within their reach. As we forge ahead towards a new normal, we call on everyone to be the solution. It is a significant behavioral change in all areas of our life that will keep us and our loved ones safe. Let us continue to spread the word and help those which may not be informed or motivated. So that way we can reduce the infection in our country and we can shift into this new normal that we talk about. So thank you very much to all of you, and over to you, Professor Joyce.
Thank you very much, Yusek Vergere, for that very informative presentation. Thank you for all those updates that directly impact on our hospitals and presenting the current needs in our hospital sector, even the gaps, which actually open several economic opportunities. Right now, we have received over 200 questions from our participants, and thank you for covering some of the points in your presentation. But we will reserve all those questions for you during the open forum. So I hope, Yusek Vergere, you will stay with us to address all these questions. Thank you again. And so we moved on to the other side of our discussion. I believe this is the first time that we are engaging the Philippine Chamber of Commerce and Industry in this forum with the hospital sector, which I believe should now become an integral part of the business community. After all, we need every good businessman to be healthy because they drive our businesses, isn't it? So, ladies and gentlemen, the President Emeritus of the Philippine Chamber of Commerce and Industry, and also the private sector representative of the Legislative Executive Development Advisory Council, or LEDA. Ladies and gentlemen, my privilege and honor to present to you Mr. George Barcelon.
Good afternoon, all. I'd like to greet, of course, my good friend Joyce for inviting me here, and also Governor Obit, and my fellow panelist, my good friend BAP President Mr. Bonsing, and I'm glad to be here. You know, this is not really my cup of tea. First, there is the digitalization of all medical records in fighting any disease, but even more urgently, a pandemic-level disease, information and sharing of information is the most basic and most crucial tool. Correct timing, accessible and reliable information saves time, cost, and most importantly, lives. Evidence-based and science-based medicine is possible without quality information that gives us the basis of better strategies and better decision-making. I would leave this to the expert in the medical sector. Secondly, we need our policymakers and partners in government to consider and implement incentives to the importations and modernization of hospital equipment and facilities. This can be done by making funds available and interest rates more affordable for hospital, wherein nearly all of our hospital equipment and supplies are imported, even our chemical reagents. We can be resourceful in providing incentives so that hospitals find it more efficient and cost-effective to level up the standards and the quality of their health care. Third, compliance to or the achievement of international accreditation is simply the way to go. Moving forward, no hospital in the Philippines or any other countries is truly local. With teleconsulting and digitalization as part of the new norm of healthcare, Philippine hospitals are called upon to be at par with the best hospital in the world. Once we share this vision and work together to realize it, there's no reason for a hospital not to pass the audit of global experts and international accrediting bodies. Fourth, we need continuous training and upgrading of knowledge, skills, and technology. COVID-19 is a new disease. Its effects on human health are still being fully discovered. It is a virus that evolved to challenge not just our immune system, but our capacity to adapt, to be resourceful and creative. And this is something that is, for us, is uncharted territory. And may I add that we're not the only country facing this. All over the world, even our ASEAN neighbors are having issues dealing with the COVID-19. But some of them have been able to deal with this and reduce their infection. As we know very well, our healthcare per capita is slower than our ASEAN neighbors like Thailand and Vietnam. Vietnam is catching up very quickly. Their annual budget for healthcare is 17 billion US dollars, and with a slightly smaller population. And same as Thailand, if you look at the per capita, we spend about $150 per capita, where Thailand spend about $250 per capita. And this is where we know that we have to raise our standard and also our capacity. Maybe at this point in time, I'd like to add, like countries having this vision have moved forward, not only just servicing their local communities, but also encouraging medical and wellness tourism. Thailand has been having quite a bit of success and foreign investments coming to in their country and attracting people from all over the world to experience the upgraded medical service that they are able to provide. So in short, we ourselves need to evolve our knowledge and acquire technologies and to keep up with new diseases. This has to be part of our hospital DNA. And fifth, we need to prioritize investments in healthcare. This means allotting more national budget to healthcare, encouraging and incentivizing investors to support healthcare ventures, and to put healthcare at the center of our efforts to build our greatest resources, the Filipino people themselves. No economic plan or strategy will succeed if Filipinos themselves get sick. To harness, preserve, and grow our human resource, we need changes in our laws, or to introduce new laws, review and revise existing policies, and simply to prioritize the health and the life of its Filipinos. This pandemic is showing us that the economic contraction we are experiencing is due to the threat of the health and lives of our people. More than anything or anyone, this enemy is real. It affects our healthcare professionals and hospitals, who are the biggest factor in making recovery a reality. And I, in my own capacity as involved in the business community, we have been at the forefront of encouraging, through the effort of the government sector, that we practice proper hygiene protocols that would be able to mitigate the COVID-19 infection. But at the same time, for us to inject life into the economy, we have, in many initiatives, talked with the government on the opening up of the transportation, like the 7 commandments. I'm sure most of you are very well aware what these are. Basically, what we do every day. If we go out, you wash hands frequently, put on a mask, put on a face shield, avoid communicating when you're in a public transportation, avoid talking, avoid eating, avoid close contact. And these are all ways and means that we can hopefully build up the confidence in our public, and which is really needed because without the confidence of our consuming public, our economy would lead to stagnation. So please let us not ignore the urgent need. More than ever, let us all support our healthcare system through better policies that needs to be upgraded and updated and needed, and what's the other investments that are needed to make it enough to handle not just a global pandemic, but to provide top-level caring and cures that Filipinos and the rest of the world truly deserve. With that, I end my talk, and thank you very much for spending time. Thank you.
Thank you, Mr. George Barcelon. I almost called you King George again because I him as a royal.
I know. Yeah, thank you for that. Yeah.
Of the town. Okay. Thank you. And as you pointed out, having healthy people is vital in a vibrant economy. And as an old adage says, no, Mr. Barcelon, health is wealth.
Yes.
Not only is one state of mind richer when healthier, but what is far more telling is the productive potential when the effect is cumulative on the nation's gross domestic product. A healthy nation is indeed a wealthy nation, right, Mr. Barcelon?
So, yes, I support that.
Thank you. At this point, we're going to have a 5-minute intermission. We're not yet done. We're going to we'll move the direction to the other side of the fence, so to speak, as we listen to the economic experts, our bankers, and also the Board of Investment. We're going to have a 5-minute intermission, and then we will immediately proceed to the next part of the forum. So please don't go away. We will resume in 5 minutes. Thank you.
Thank you.
Healthy people are dying in hospitals. Every year globally, more than 4.8 million people die from preventable causes. Preventable deaths in hospitals are the third leading cause of death in the U.S., behind heart disease and cancer. And this problem isn't just measured in human lives. The social cost of in-hospital adverse events is estimated to be between 18 and 45 cents of every dollar spent on U.S. healthcare. That means of the $3.5 trillion spent on healthcare in 2017, medical errors account for $1.44 trillion. This all may feel unsettling, but there is hope. We are the Patient Safety Movement, and we've made a commitment to drop the number of patient deaths by preventable causes to 0 by 2020 by unifying the healthcare ecosystem and implementing a commitment-based movement, actionable patient safety solutions, and an ecosystem for predictive algorithms through data sharing. We can, together, eliminate preventable deaths and dramatically reduce the cost of healthcare worldwide. Last year, we reported 81,533 lives saved by committed hospitals. And this year, we're excited to report that 90,146 lives have been saved by hospitals that have taken action. And with your help, we can get to 0. But we must act quickly, as we're going to need everyone to lead us to 0. We're going to need policymakers to create incentives for change, healthcare technology companies to sign the Open Data Pledge, and healthcare providers to implement proven processes such as APSS to save lives, so that patients survive and families don't have to mourn their loved ones. Your commitment could make all the difference for her family, his family, their family, and your family. This is more than a mission. It's a commitment-based movement. Commit today so people can live tomorrow.
Thank you so much, everyone. I hope all of us are back. Please, again, we would request all of you to please stay on because we are going to have an open forum and all our panelists will be invited again so that we can address all the questions that have been sent to us. All right, so at this point, we would like now to hear from the other side, our financial sector. In this session, we would like to know how are the financial institutions extending financial relief to the hospitals and their suppliers, and how do they promote continued access to financial services and hasten the recovery and sustainability of their businesses during and post crisis period. We are privileged to have with us the president of the Bankers Association of the Philippines, who is also the president and CEO of Bank of the Philippine Islands. You can see his entire profile on our website. Ladies and gentlemen, my honor to present to you Mr. Cesar Contin.
Well, good afternoon, Professor Alumno, and greetings to my fellow panelists, Dr. Jaime Almora, Yusek Rosario Vergere, PCCI President Emeritus George Barcelon, and Executive Director Maria Corazon Dichosa. Thank you for the invitation. I'll give a few remarks and then pass it on to my colleague, Jovi Alonso, who is Chief Credit Officer of BPI, who will talk about some of the issues we deal with when we look at hospitals and financing hospital operations. But first, a quick overview. The country's credit metrics clearly remain very strong. The debt to GDP levels are fairly low. The peso has strengthened over the last few months, and we have maintained our BBB plus sovereign credit rating. But the strong credit rating is not necessarily equal to economic well-being, as you well know. They aren't quite the same. And if you look at all the BBB plus countries in the world, the Philippines is probably the poorest in terms of per capita income of the world's countries that are rated BBB plus. The Undersecretary and Mr. Barcelon talked and referred to low medical spend per capita relative to other countries. And this is just a proxy of the issue that I've just raised. This year, when you look at the growth rates that we've been seeing quarter on quarter, it's easy to imagine that GDP growth for the year will be in the order of negative 10% for the full year. Just to put that in perspective, for those of you who are old enough to remember, and I suspect that's a minority, of course, George and I will remember this. During the debt restructuring crisis of the early 80s, we had a couple of years, 84 and 85, where the Philippines grew by negative 7% a year. So in other words, the country shrank for 2 consecutive years. In the Asian financial crisis, the crisis that ran from 98 to about 2002 or 2003, in the very first year of that crisis, the Philippines shrank by about 2 or 3%. So that gives you an idea of the magnitude of shrinking in the order of, call it 10%, maybe more. Fortunately, by every indication, we are seeing green shoots of growth throughout the country as the lockdown lightens and the economy opens up. And so I would not expect 2 consecutive years of negative growth. In fact, next year we expect quite buoyant growth, something in the order of 7, maybe 8%. That being said, full recovery will not come back until probably the year after, 2022. If you look at loan growth this year, in other words, credit growth, as of the end of the third quarter, it was only tracking 2.8% year on year. This is the lowest growth rate we've had in more than 10 years. And it reflects the fact that times are more difficult and aggregate demand is low. What surprises me personally is if you would have asked me what would have happened to the healthcare sector in a crisis like this, I would have told you, without knowing what has since happened, that the healthcare sector would be very robust, that in fact it would be buoyant. And so I'm asking myself, why is it in a time like this that the healthcare sector is actually quite challenged, right? When it is so important to everything we do right now, it is so central to our lives. By our estimates, the gross value added of the healthcare sector this year will only be about 86% of 2019 level. So that's a drop of 14%. That means the healthcare sector is shrinking faster than the economy as a whole. And when you think of how central it is to our lives now, it really raises the issue, what is happening? Okay? By most indications, the healthcare sector will recover with the economy. And by our estimates, we should be back to gross value added levels that we saw in 2019 by 2022. So we think that's probably a year and a half, 2 years away. When I talk to my colleagues about economic metrics, I ask them, forget about looking at -10, -11% growth rates. Just think in terms of how long it will take to get back to pre-COVID levels. And by that measure, we think for the healthcare sector, it's probably the order of 1.5 to 2 years. What surprises me about the negative growth that we've seen in the healthcare sector this year is that in a situation like this, it's almost like a utility, or it should be a utility. In fact, when you look at the other utilities in the country, telecoms, water, power, they are pretty much, or by the end of this year, they will be back to pre-COVID levels in terms of gross value added. But we don't see this in the healthcare sector. So with that, what I'd like to do is pass on the floor to my colleague, Jovi Alonso, who is the Chief Credit Officer of BPI. And he will go through some of the issues we see that are fairly unique to your sector and explain why things are the way they are. Thank you very much.
Thank you so much, Mr. Kansing, for giving us an overview and also your own personal views as to how our economy is going to cope in a couple of years. And I don't know if it's encouraging or discouraging to note that it may take us another 1.5 to 2 years to actually some recovery. If you wouldn't mind, Mr. Kansing, we would like to have you during the open forum because I know a lot of our participants have some questions in mind. But as you just said, we are going to turn the floor to your Chief Credit Officer, who is also the Senior Vice President of Bank of the Philippine Islands, who will present to us more information as to how the banks are responding to these financial challenges and these waves that are now actually rocking the boat, so to speak, of our hospitals. Are they able to provide more flexible and favorable lending terms to our hospitals and their suppliers in order to carry on with their businesses during this pandemic and post-pandemic? So that's just one of the questions we would like to hear from our next panelists. Ladies and gentlemen, the SVP and the Chief Credit Officer of the Bank of the Philippine Islands, Mr. Joseph Anthony Alonso.
Okay, are the slides up? Okay, can we move to the next slide, please?
Next slide, please.
Oh, great.
Now it's moving.
Okay, okay. In the interest of time, I'll try to go through this as quickly as possible. As I mentioned earlier, we have basically the same criteria we apply when it comes to hospital loans. We look at it the same way we look at other business enterprises. Number one, we look at the sponsors, of course, the investors. Number two, we evaluate the project, the viability of the project itself. Number three, the amount of capital infused by the investors. Number four, the collateral offered. And number 5, the prevailing circumstances wherein the project will be implemented. Of course, the other conditions include also the specific purpose of the loan, the amount, the interest rate to be charged. The application of these have been consistent, with variations and adjustments only being made when, depending on the prevailing circumstances. In the current situation, with the onset of the pandemic, heightened risks with regards to repayment of loans have been observed. Next slide, please. Okay. For hospitals, generation of revenues and income have been significantly hampered due to the general fear of people to visit hospitals, resulting in greatly reduced OPD and admission census, non-operation of clinics, and the shift to telemedicine, video calls, or online consultations. Revenues from diagnostic procedures and ancillary services are sharply down, and elective surgery procedures completely stopped as well. Expenses, on the other hand, are also increasing as measures to enhance disinfection and prevention protocols and frequency of implementation of prevention protocols, provision of PPEs for personnel, and procurement of testing kits and equipment are also driving up operating costs. Fear of contracting the disease not only affected patients, but also hospital staff, resulting in some hospitals closing entire wards due to limited number of nurses and staff. With cash outlays increasing versus minimal revenues coming in, the risks of hospitals defaulting on their loans has multiplied and may even result at worst in bankruptcy for some institutions if not addressed immediately and effectively. Next slide, please. Okay, the causes of financial distress among our hospital clients, ones that we've observed, comes in various forms. Aside from lost revenues and higher expenses due to the pandemic, other risks we see are non-payment for services rendered. Here's where you see most of your clients that cannot afford to pay for the services rendered, issuing PNs, collection of which is still uncertain. Then we have extremely delayed receivables collection, most notably from PhilHealth, which has become increasingly common among our clients. And mounting payables to suppliers because, of course, equipment has to be purchased, medicine has to be purchased, supplies have to be purchased, but paying for these has become a burden also. Unutilized expanded facility, as I mentioned earlier, closure of entire wards because of lack of personnel. And for these entire wards or whatever expansions that the hospitals undertook during better times, these may have been funded by loans. And also, of course, there is this increasing demand for hazard pay among our hospital personnel, even the support staff. There are still a great many other causes that may be cited, and the ones I mentioned are the most common that we encounter. There is no generic fix that can be applied to all of these situations since each hospital is unique. So how do we manage these problems, you may ask? Next slide, please. Okay, similar to a hospital setting, we also do a triage. Client in distress is similar to your patient entering the ER. We take patient history, observe and classify whether the patient needs further diagnostic tests, call out to our senior consultants for advice, or the patient is immediately conveyed to the OR for emergency surgery. Generally, those that have the least amount of loans and whose cash shortfalls are only seen as temporary are provided assistance via deferment of loan principal payments for a set amount of time, or granted bridge loans to settle critical payables to enable operations to continue. Those that are in the middle of investment or expansion activities and have already assumed a sizable amount of bank borrowings, as well as payables to equipment suppliers, are in another category. Some may be already experiencing cash flow problems that are making it difficult to continue operating unless immediate drastic measures are implemented. These will require more intensive attention and review, similar to surgery, and will most likely require loan restructuring via a combination of payment deferrals, and a detailed consultation to reassess the entire hospital operations and may involve postponement of planned projects or capital expenditures to save much needed cash. Again, similar to post-op recovery and rehabilitation. Now, totally new projects is another matter, especially during these times of COVID. Well, we also have to study these new project proposals carefully. We understand the need for additional hospital beds that a country like ours is in critical need of. So we, as much as possible, we'd like to support as well. But during these times of heightened risks, stricter lending parameters will also have to be implemented to ensure that repayment will be done. This, however, does not mean that the financing window for new projects is already closed. Rather, we would have to be more discerning in assessing which projects would have the most chances to eventually succeed. What indicators do we look at then? First and foremost, of course, as I mentioned earlier, are the people behind the project. Do they have successful track records in establishing and managing a hospital? Do they form a cohesive group? Will this group that invested into a particular hospital, most of them are highly qualified doctors and specialists in their fields, but could they work together as a group when the hospital goes into financial distress? So we look at that as well. And what is their formula in ensuring the hospital business becomes a success? Do they have a specific niche that they're looking at that they can serve? Is there an area that they feel that is underserved, that in the long run will eventually pay off in terms of providing services to address these needs? Will the project be something that the community would need? Is the hospital that's being put up too ambitious to be placed, let's say, in an area in which the community cannot afford to pay for all these services? So if that is the case, then the hospital would probably be running into financial problems sooner rather than later. How much capital is being invested? The more capital that is invested, the less need for the banks to provide financing. And it also is a reflection of the commitment of the stakeholders in seeing the project through. How much would the loan required? How much would be the loan required, and how long would be the repayment period? We have to work on this together with the project proponents, because we look at the project in a different way compared to the project proponents. When the project proponents would probably say they can repay the loan in 5 years, but in our view, it could be 10 years, so we have to discuss that. Of course, the interest rates would vary depending on the tenors of the loans. Then we also look at projected cash flows. Would these be sufficient to repay the loan? What collateral is there to secure the loan? How much is the lending rate? These are just some of the questions that need to be addressed before financing could be extended. I'm afraid I have to end my talk at this point in the interest of time. I hope I was able to paint a picture of how we view hospital credits in a simple way. In summary, I would say that banks, being fellow frontliners, have been extending assistance to our hospital clients in various ways to support continuous, meaningful delivery of healthcare services while trying to ensure the long-term viability of hospitals as businesses. Let me end by quoting Benjamin Franklin. Next slide, please. He once said that an ounce of prevention is worth more than a pound of cure. This quote is generally believed as relating to medicine, but it was actually intended to address fire safety. By extension, this also applies to business. Identifying and addressing the causes of distress early will definitely help in avoiding much larger financial difficulties in the future. Thank you, and keep safe, everyone.
Thank you so much, Mr. Alonso. I hope you will stay behind because that was a very interesting talk that you had. And thank you for giving us some guidelines as to how our hospitals and, of course, their suppliers and providers can access your financial services. At this point, we will have a slight change in our schedule. So instead of moving to our next panelist, which is the Board of Investment, Yusek Vergere will have to go soon. So she will not be able to join the open forum later. But then we are going to ask questions already. So if we can put on the screen, put on spotlight, Yusek Vergere. Is she still around?
Yes, ma'am, I'm still here.
Yusek, I know we all know that you're very busy. Every second matters to you po. So at this point, we're going to show several questions. Actually, Yusek, we had over 200 questions for you, not including the chats that we have been receiving. But what we did was we grouped them together into 7 areas. And in fact, a lot of them you have already answered in your presentation, which was very comprehensive. And I hope you will allow us to distribute the slides that you have shared. We also have people from the media who said that if they can get a copy of your presentation. So, because that was very informative. So, Yusek, we have here 7 groups. Okay, so 7 major topics. One, the first topic is on COVID-19 risk management strategy. The second major topic is about health. The third major topic of the questions is on the strategy and also on public-private partnership, quality assurance, nurses, and licensing and regulations. So at this point, can you put on spotlight Yusek Vergere and also the questions so that we can flash all of them? Yusek, in the interest of time, of course, we know you have to go. We have already grouped them together. Can Yusek Vergere see the questions? Can we go to the first slide, please? You can actually answer all of them at one time na po. Okay? So maybe I can read through them quickly. Yusek Vergere, while you are also reading that on screen. The questions related to the COVID-19 risk management strategy is that one of the preventive and mitigating strategies that we have seen to be effective in containing the virus in other countries is that they bring all the COVID patients in COVID designated government hospitals, such that all the private hospitals are able to attend to all other cases and there's no fear of getting affected or infected by the virus. In our case po, we have actually, in fact, you mentioned RA 11494, in which the hospitals are asked to allocate 20 to 30% of their bed for COVID-19 patients. What is the reason behind this strategy? And is there also a possibility to designate COVID-19 government hospitals across the region so that all provinces are covered? That's one. Yusek, sorry po. Again, another question related to COVID-19 risk management strategy. Do we have any update, especially on the effect of this strategy to the NCD services, the non-communicable services? How did it impact? Kasi po, we have a lot of chronic illnesses already existing even before COVID-19. And then another question po is, how are you able to know the rate of infection in areas where there are no COVID-19 testing facility? Can COVID-19 testing be provided for free? And the last one, which you might find a bit candid, is what is the main reason behind entrusting IATF for COVID-19 to former military personnel rather than to doctors and experts of infectious diseases? Has that become advantageous to our economy? Or is there really a separate task force for from the health authorities to answer these problems or this crisis? I'm sorry, that's just for the first major part, Yusek.
Sige, thank you po, Professor Joyce. No? So first, yung sa COVID-19 dedicated na hospital, this order applies to all the hospitals in the country. No? So it applies to all regions and provinces that they are mandated that they should have this designated COVID-19 government hospital. It also applies to private hospitals kung i-identify ng government, national government, that in a specific area, there are no government hospitals capable, we can do that because of the pandemic. No, it's just a matter of discussing it with the private hospital identified. Now, the reason for this strategy is for us to be able to have more focus, no, in managing the cases for COVID, and of course, this is for equity and access as well. As we all know, there had been this issue, especially in Metro Manila, when the surge of cases, no, during July and August, when the cases increased, no, and then there were no uh, available facilities for some of our uh, kababayans na pupuntahan nila for COVID, no? So what we did, we had the one hospital command, and then of course the designated hospitals were really mobilized. Actually, just for the information of everybody, when we started our response for COVID-19, I think that was March, we already designated three big hospitals for COVID. That was the Philippine General Hospital, Lung Center of the Philippines, and the Jose N. Memorial Medical Center, that was the former Tala Hospital. They have dedicated about 30 to 40% of their capacity for COVID-19 at the outset. Even PGH, they have to close some of their operations because they agreed with government that they will be a referral hospital for COVID-19. We wanted to adopt the strategies done in other countries where they only have a single facility or identified facilities that will be catering to this kind of cases, so that we can prevent the mix of cases within hospitals, within facilities. Also, the healthcare workers, no, would only have one focus when they attend to patients in that specific hospital. So that is really the strategy. And of course, as I've said, access and equity would be part of the reasons why we have to do that. So for now, in the different areas, priority areas, they were able to identify COVID-19 hospitals which are designated for that specific purpose. In Davao, we have SPMC. In Cebu, we have the Vicente Soto. Here in Metro Manila, as I've said, we have these three big hospitals. And of course, we have COVID referring hospitals wherein they can screen, they can triage patients, and then after that, they have to refer it to the COVID-19 designated hospitals. So the second would be updates on the NCDs. When we had, if you would if you would notice, no, our objectives and goals for COVID would include COVID pathways and non-COVID pathways. Our major goal for this response is for us to reduce deaths, both for COVID and non-COVID. So when we responded to COVID, we did not lose or we did not stop the essential services that is being provided by the government. But of course, we recognize that fact, no, that some of the patients, no, have difficulty accessing their services, especially for dialysis patients, for cancer patients. That's why when we had our in the middle of the year, we had this COVID dedicated or designated hospitals, and there were COVID referring hospitals, so that we can be able to delineate, no, the functions and the access where patients can go to when it's really just for non-COVID services or for COVID services. So do we know the rate of infection when there are no COVID-19 testing facilities? For now, all of our regions already have COVID-19 laboratories. Although, of course, some of the provinces and some of the cities still do not have it, but there is this referral network where they can send their specimens and they can have the results. Although the turnover or the turnaround time would be much slower in these areas, but still we can diagnose. And the country right now, through the government, is exploring new diagnostic methodology so that we can have more access to these COVID-19 testing facilities or COVID-19 tests. So isa po yan sa pinagtatrabahuan natin ngayon so that the access to these laboratories will be increased and everybody can be able to access. So COVID-19 testing is free. When you go to a government facility, it is for free. It is being paid for through the PhilHealth benefit package. So yan po ay libre kung sakali man pong may naidagdag or there is this top up aside from the PhilHealth. Ito po yung mga minimal charges ng ating ospital because they also pay for some other logistical requirements for this COVID-19 test. And main reason for the IATF having military people, these military people are the cabinet secretaries of our president and our national government. And it is not just them deciding for this. This is a collegial body. Actually, the Interagency Task Force for Emerging and Re-emerging Diseases is based on law. Meron po tayo talagang batas that it should be mobilized as soon as there is an epidemic or a pandemic. And this interagency task force is a policy directing body where the decisions are collegial, pinag-uusapan, there are criterias and there are recommendations. And then the IATF always, no, we have these experts, they are scientists, they are medical experts, which who are being invited, no, every time there are scientific matters to be discussed and to be decided on. So it is not really for them to think about these different strategies or think about these different scientific details. It is governance, no? IATF is there for governance, for overseeing, for directing, but the scientific details, the technical part is being done by the Department of Health together with all of our medical experts and scientists. So it is not really them only, but it is a collegial effort. It is a whole of government and the whole of society approach.
Okay, thank you so much, Yusek Vergere. Next slide, please. Thank you for those very comprehensive answers. For the next topic is on PhilHealth. You don't have to go through all of them, Yusek, but I think the key point for this is that what's the update on PhilHealth? Everybody was very bullish on their projections during the start of the year, especially with the implementation of the Universal Healthcare Law. So now they're caught in the middle and they don't know what to do for next year. So what will happen to the UHC implementation? Is there a timeline? And also, will the PhilHealth, what's the plan to reimburse the struggling hospitals from their outstanding receivables? And the last one is that can teleconsultation or telemedicine be covered by PhilHealth? Because many OPDs have already opted to close during the pandemic. So maybe just to concentrate on those three items you said. Thank you.
Yes, ma'am. Actually, universal healthcare will push through. There is this reorganization being done in PhilHealth, and there is this they are trying to re-strategize as well so that we can be able to accommodate what is needed for the universal healthcare. So universal healthcare will push through, and the funds are there. Actually, they have recomputed, no, based on the assumptions that has been given by the Philippine Health Insurance Corporation, how much their reserve funds are, how liquid they are, and how long these funds would last. No, so there is this recomputation, and it has already been discussed. And maybe in the coming days, the president of PhilHealth would be able, no, to give that information to everybody, including our partners in the private sector. But definitely, UHC will not stop from being implemented. It's going to push through. Now, when you look at the different provisions of the universal healthcare, it has in one of the provisions, it has classified the services that will be covered by PhilHealth and the national government through DOH into population-based services and individual-based services. So it has somehow rationalized how PhilHealth would be funding for services. And of course, national government, that we prevent duplication in the funding of these different health services that we provide to our people. And that would lead to efficiency, and that is the goal of UHC. So when you say it's population-based services, it is the national government through DOH that is going to subsidize. And when we say it's individual-based, it's going to be PhilHealth. This somehow will be able to have provide us with some fiscal space. Because before, even though the national government subsidizes already, PhilHealth still pays for it. So it's being duplicated, and we are losing a lot of resources by doing that. So with this strategy within the universal healthcare, we'll be able to make our financing more efficient, and therefore can create more space that we can provide, no, and pay for the other services that are not still included. Second, the other services that especially are very important right now in this kind of situation is already being studied by PhilHealth. We have to remember that included in the Universal Healthcare Act is the establishment of or creation of the Health Technology Assessment Council. So every time PhilHealth develops a package and every time DOH will procure something, we have to go through the HTAC because they would be assessing the cost effectiveness, the benefit for government, the feasibility of implementation, and of course, the ethics and the equity side of it. So when we talk about the telemedicine, we know that it's very important, but we need to have the Health Technology Assessment Council go through it, our experts there, so that they can give us recommendations if government will be efficient when we cover this kind of service and if the population will benefit. So that would entail this process, and of course we know that this is immediate, so it is part of the radar, that PhilHealth is scoping right now. So for the outstanding receivables, I will apologize for that. I will have to have PhilHealth answer this question for everybody.
Understandable. Thank you so much, Yusek Vergeire. For the last slide, because there are other four slides, but I think we'll just keep you for another slide because you already mentioned several proposed strategies, on how we can move forward and also the public-private partnership initiative. So you can skip some of the questions here that you have already covered. Okay, you mentioned about the proposed budgets that you need in order for us to fill in those gaps and based on the needs that you have also identified. But it was observed by some or by many of us that despite the uncontrolled increase in the population, the budget is being reduced. I don't know what will happen for 2021 and in the next years. The question was, is this a result of misappropriation or underutilization, or is the budget going to be increased for next year and for the coming years, especially for 2021?
Yes, ma'am. No, so I just like to explain this further because a lot of people are saying that the main reason why we have underutilized the budget for the health facilities enhancement program would be this weakness in the planning and all of these issues. First, when we talk about infrastructure, we usually know, and if we usually cannot really complete a specific project in just 1 year. You get your funds maybe the first end of first quarter until the second quarter, and then you start your infrastructure project. But it's never going to finish that you have this finished project at the end of this year. You have to remember our budget is good for 1 year. They give us the budget for 1 year, and then we, of course, we have the procurement process. We allocate, we obligate, but the project, we will see the product maybe after 3 years, no, of doing all of these projects. So since 2009 that we have receiving this health facilities enhancement project, the different projects per year, no, has been overlapping because of this. As I've said, it takes 2 to 3 years to complete a project. So when we have this monitoring, and of course we have other agencies of government that will monitor us also. And because of this historical, apparently that they say that we cannot utilize fully our funds, that's why the money for health facilities enhancement program was slashed off for this year, for the coming year, I mean 2021. So the infrastructure projects were put into a hold, but we appealed because there are projects already that are going to be finished already. They have already been started, and if we stop the funding, and then they would be idle for 1 year, and it will not be finished, and it will, it will go to waste. That's why we have appealed, and I think our the Department of Budget and Management, of course, our legislators were able to listen, no, and they were able to commit that they would be adding some more so that we can finish those already started projects for our health facilities. Now, with this health facility development plan, this has been approved by the president, and we already have redirected, no, this plan because of this current pandemic. So the answer, how do we prepare for this next pandemic? We saw our weakness, no? So whenever there are these huge things that happens in the health sector, you take this as an opportunity for you to see the weaknesses, the gaps, and all. And that is what we have done. Seeing the weakness, seeing the gaps during this response that we have, we were able to redirect this plan so that for the next pandemic, we will be prepared. So hopefully, we will get to have funds so that we can be able to pursue this identified plan for our health facilities, and that we may have this kind of capacity whenever there's a next or a succeeding pandemic after this. So do we have an approved budget? We got our approval last night at 12:30 in the morning. The Senate approved our budget, and I think they have committed also to add up to our health facilities money, and also the operations money for some of our big hospitals. So what are the measures? Sustainability for human resources. We have our health human resources plan, where we are partnering already with the different sectors, and also we are encouraging local governments to produce their own. No? So this is one of our strategies. Our local governments have their own universities, state universities. Some have their own medical schools in their locality. So if we can be able to produce our own and let them, make fund for them, and then they can stay on to work for you. So that's especially for those far-flung areas, we can have our healthcare workers. But aside from that, also we have different strategies that we are now employing so that we can increase, no, especially for the allied healthcare workers that we are lacking also right now. So, what is the plan of DOH to enhance the capability of government and private hospitals? So, as I've said, we have this health facility development plan. Aside from that, in the UHC, what we have that what we have there would be something which would be the foundation of all of these things that we are discussing. That is for us to strengthen the primary care facility so that there would be gatekeeping mechanisms. If you would notice right now, there is no gatekeeping. So the patients who can afford to pay, or even those who cannot afford to pay, they do not pass by the primary care facility, even though they are only going to consult doctors for minor illnesses like cough and colds. They would already go to the ER of a tertiary hospital, and this they would say I can pay, but they do not know that the government also gets burdened, no, with this kind of system. That's why we would want the primary care facilities to be strengthened, that there would be a network between the public and the private for these primary care facilities, so that if we can have this kind of system, that primary care facilities are already capable, and then we can lessen those individuals who are bypassing the system, going to the higher level instead of just going through this primary care facility. So we have the healthcare provider network, and this is part of what we are trying to establish right now in the different areas of the country, so that we can be able to improve the health system capacity. So the last would be, why can't government standardize, if not align, the salary of healthcare workers in private health institutions with government hospitals? So we have different mandates, and we have the dictate, no, of the different laws that we have right now in the country. And it is part of what we implement based from the salary standardization that has been implemented by government. What we hope would be that the private sector would follow, so that there would be this competitive salaries from the private sector side, and that healthcare workers will not migrate or would not shift to the government, and they would try to have their retention strategy if only they can match the salaries coming from the government sector. So I think that's all, Professor Joyce.
Thank you so much, Yusek. I will not show the other four slides. There were several questions posted there, but I think for the sake of some of our healthcare providers, is just one last question. Are you looking, especially on the pricing, no? Are you looking at implementing some regulations about hospitals overcharging? And are you looking into price banding for the hospital rates so that we can somehow regulate the healthcare costs? That's the final question for you, Yusek Rahire.
Yes, thank you, ma'am. Actually, since we had PhilHealth benefits and the system that they do for payment, shift from the pay for service to this case rates and the other bundled payments that they are implementing. This was one of the strategies that government has provided so that we can somehow regulate prices. Because with these bundled payments for PhilHealth, we can assure that the cost for the professional fees, the cost for the laboratories, the cost for the inpatient, medicines and all are all bundled up together. And this will have that cap for the specific services, and somehow we can regulate prices. Unfortunately, this bundled payment, no, that PhilHealth provides to our hospitals are still being there is this practice where the hospitals would still ask for more on top of this PhilHealth bundled payment. So that is the issue that we have right now. Instead of us being able to regulate this through this incentive mechanism for the PhilHealth package, it was the challenge was there, no, that hospitals are still adding some more cost to patients aside from the PhilHealth benefit package that is being provided. So the order coming from the secretary, who is the chairman of the board, is for PhilHealth to recompute your bundled payments that you are including into these benefits that we are offering the public, so that we can see why private and the other hospitals or the hospitals themselves are still adding some more. Maybe they are not getting what is due to the services that they are offering. So that is part of this redirection and re-strategizing of PhilHealth. And hopefully in the coming year, no, 2021, we can be able to set a standardized, no, regulatory process, regulatory payment mechanism where PhilHealth can be able to implement this bundled payment that is both acceptable and is equitable for everybody.
Mhm. Okay, thank you so much, Yusek. We have to let you go, we know, but thank you so much for being so generous in answering all our questions. If you don't mind, we will send you all the other questions, and hopefully you can also address them. We wish you well, and we thank you so much for your hard work and for spending a lot of time with us today. Thank you so much, Yusek Brahire, and all the best to you.
Thank you and
Thank you very much.
congratulations.
Thank you very much. Thank you.
Thank you, Undersecretary Verheire. All right, so in order for us to catch on with our time, I know we're quite delayed. We are going to show the last panelist, which is, I believe, a very important topic for all of us to see the other opportunities that are in store for the healthcare industry. We will have with us the Board of Investment Executive Director, Ms. Maria Corazon Dichosa.
Good afternoon, and thank you for inviting the BOI to this webinar. For those who are not very familiar with the Board of Investments, we are DTI's lead agency responsible for industry development and investments promotion in the Philippines. We take the lead in the promotion of investments, assist Filipino and foreign investors to venture and prosper in desirable areas of economic activities, and we register qualified activities under the relevant Investments Priorities Plan, or the IPP, and administers incentives to compliant registered projects. Now, the basis for the qualification as well as for incentives availment in the BOI is the Investments Priorities Plan, as mentioned earlier. Currently, the prevailing IPP is still the 2017 IPP. And we have actually listed here 10 investment preferred activities. But for this afternoon's topic, the relevant of which would only be number 4, healthcare services, including drug rehabilitation, and number 7, innovation drivers. Now, for healthcare services, this covers the establishment and operation of general and specialty hospitals and other medical healthcare facilities, including drug rehabilitation centers. Any of the following may qualify for registration. So general hospitals, levels 1, 2, and 3, in any of the locations listed in the Annex C1 and C2 of the IPP, and specialty hospitals, as well as other medical and healthcare facilities anywhere in the Philippines outside of Metro Manila. For the definition of general hospitals, as well as the coverage of what are general hospitals, specialty hospitals, and other medical and healthcare facilities, these are actually defined in the IPP as well and made in accordance with the DOH administrative order. Now, only revenues derived from medical and diagnostic services rendered by the registered entity shall be entitled to ITH, and any income from lease or rents and revenues from any other non-treatment related services will not be eligible for ITH. Now, prior to start of commercial operations, the registered enterprise must submit the license to operate or accreditation or certification, whichever is applicable, issued by the Department of Health. And prior to availment of ITH, the registered enterprise must submit a copy of the certificate of field health accreditation wherever applicable. Now, for the other one on innovation drivers, there are two activities that are preferred here. So one is research and development, and this covers all research and development activities and the establishment and operation of facilities for the conduct of clinical trials, including drug trials. This would be the contract research organizations, or the CROs. So for example, the CROs that would conduct clinical trials, for example, for the COVID drugs like remdesivir, or for example, the COVID vaccines, this would be qualified for BOI registration. Now, the registered CRO must submit a copy of permit to conduct clinical trials from the FDA before the conduct of each clinical trial. Another activity would be centers of excellence, and this covers the establishment of institutions specializing in technical education and training in various disciplines in centers of excellence or centers of development. For the healthcare sector, this could be, for example, centers for cancer treatment or centers for heart disease, or maybe eye, and other specialties that we may need to develop in the country. Now, the application for registration must be accompanied by an endorsement from the CHED or other government agencies that would be relevant to the application. Now, also very important for us to understand is the project type and status of what would be applied with the BOI. So as to project type, that could be new, expansion, or modernization and rehabilitation. For new projects, this could be new entities, for example, projects of companies newly incorporated with the SEC, or it could be existing enterprises who would do new undertakings, separate or distinct from the existing activities. So, for example, if you're having a pharmacy operation, then you would like to establish a hospital, then that hospital would be considered as a new project. Or for example, you have a new hospital, say in Quezon City, and you would like to establish another hospital in Batangas, then that new hospital in Batangas would be considered as a new project. A project could also be expansion, and this would be by existing entities who would like to, for example, a hospital. There would be additional beds or additional wings to that existing hospital, then that would be treated as an expansion. And then if, for example, you want an existing hospital to be modernized, like you would like to replace the equipment with new and advanced equipment, or you would like to renovate the building because it's quite old and dilapidated, and you would probably install some IT processes or technology in the hospital, that could also be considered under the modernization. Now, as to status, that could be pioneer or non-pioneer. For pioneer, that would be for hospitals or healthcare services, that could be the application or the use of new technology, new treatment, or new processes that are not yet being done in the country. Or it could also be, the third category would be services activities for the attainment of national goals as predetermined by the BOI board in consultation with the relevant agency. But for this last category, we don't have a specific program that has been predetermined by the board. But if you have any ideas, you could probably inform the board, and we can probably do the necessary consultations. And of course, anything that's not pioneer would also be now falling now under the non-pioneer status of the project. Now, very important to determine the project type as well as the status, because that is where the period of incentives will be dependent upon. So in the case of income tax holiday or the ITH, if the project is new and pioneer, that will be 6 years of ITH. and also if located in a less developed area, as identified also in the IPP. But if the project is new and non-pioneer, that will only be 4 years of ITH. And if expansion or modernization, that will now be 3 years of ITH. Now, there's also the duty exemption on imported capital equipment, spare parts, and accessories. So this is available to all registered enterprises, regardless of whether new, expansion, or modernization, or pioneer and non-pioneer. So if you have, for example, hospital equipment or testing equipment that you need to import from outside, then you can actually avail of the duty-free or the duty exemption on these importations. And then, of course, you can have employment of foreign nationals and the simplification of customs procedures. For example, if you have these importations that you need to do for your operations. Now, the date we have for the period 2010 to June 2020, we have registered around 23 facilities, so 23 hospital facilities and 2 medical tourism facilities. These 25 projects account for 12.99 billion pesos of investments in healthcare facilities. And for 2020, we were able to register 3 to date. So that would be San Mateo Kidney Care and Dialysis Center, and the Riverview Medical Center, and the ACE Medical Center in Dipolog. So these healthcare projects or hospital or facilities have added 2,026 hospital beds. And because of the dispersed location of these hospitals, of course, there is that improved access to healthcare facilities for Filipinos. And of course, in terms of employment, that has added around almost 5,000 jobs to the healthcare sector. Now, for those who are already registered with the BOI, the board has adopted this policy on ITH suspension. So for registered enterprises that have not been able to commence commercial operation for projects that are still on pre-operating stage, you actually have 2 options. One is to cancel your registration because you think you will not be able to start on time, and that maybe even if you start, you won't be able to optimize your revenues. So you can cancel your registration without prejudice to reapplication, provided that the activity is still listed in the current IPP at the time of application, and or you can actually request the BOI to move the start of commercial operations so that you do not forfeit any of your ITH year because you think even if you start right now, you won't be able to optimize the revenues for your operations. So this would be for those who have not yet started commercial operations. Now, for those who have already started operations and was forced, for example, to suspend operations or to was adversely affected by the pandemic, you can actually apply for ITH incentive for taxable year 2020. You can continue that one, or you can actually defer your ITH incentive availment for a period of 1 year or corresponding to the duration of the operation. Your operation has been affected or disrupted. So you can actually not avail it for 2020. You can actually avail that ITH year for taxable year 2021. Okay, provided that if you do that, you will have to pay whatever is the tax due to the BIR for 2020. And that if, for example, 2020, and you will defer that, is your last year of ITH availment, then if you defer that to 2021, it will not be the whole year of 2021, but it will only be as to the remaining period or the months of ITH entitlement that you are supposed to enjoy had you enjoyed it for 2020. So that is only for those already registered with the BOI. Now, I mentioned earlier that the prevailing IPP is still the 2017, but just to inform that we have already submitted the draft 2020 IPP to the Office of the President last May. And what we have there is a carryover of the 10 activities I showed you earlier, but we also added another activity there that says all qualified activities relating to the fight against the COVID-19 pandemic. So this covers the production or manufacture of medicines, medical equipment and devices, PPE, surgical equipment and supplies, as well as laboratory equipment and its reagents. And then it also includes production or manufacture of raw materials, machinery and equipment for use in the production or manufacture of the aforementioned products. So this also includes repurposing of manufacturing activities to produce the said goods or services in the fight against COVID-19 pandemic. And with that qualifying as a pioneer project, it was also recommended there that activities under this listing of relating to the fight against COVID-19 would be entitled to ITH of 6 years. Now, even without the 2020 IPP, maybe a lot of you will have known that the BOI or the DTI has been very active in advocating for a lot of health-related initiatives, particularly recognizing the difficulty in sourcing a lot of our PPEs for our healthcare workers. So we started with the repurposing initiative, and this was to address the current requirements of the country's healthcare system and the general public for COVID-19 critical products. So we ask our electronics companies as well as our garments manufacturers to do masks and coveralls that will be used by our healthcare workers as well as the other frontliners. It was also to establish and deepen the country's supply chain in the manufacturing of healthcare products to a certain level of self-reliance, because we noticed that a lot of the countries actually imposed export bans, and so we had difficulty accessing supply of these important PPEs. And of course, since a lot of businesses were affected by the pandemic, we also encouraged repurposing to revive idle or help low utilized facilities increase their capacity utilization and hopefully retain jobs in the manufacturing sector. Another initiative that we had is the PPE Ecosystem Initiative, and this is where we had a lot of collaboration and coordination with our repurposing companies from the electronics sector, from the metal sector, from the garment sector, and there they met and agreed to produce what we needed to fight against COVID. So this initiative was to sustain the local production of health critical goods and expand manufacturing base, to reduce dependence on imports and mitigate any impact of export bans by the source countries of these PPEs, to address the supply chain gaps in the manufacture of health critical goods. Of course, for our local manufacturers, it is also important that we try to help them source the raw materials and supplies for them to make the PPEs. And also to improve the regulatory environment. So we do a lot of coordination with the FDA and other concerned government agencies. So we try to facilitate the permittings and licenses of our repurposing companies. And then, of course, there was the Bayanihan 2, which provides for the accreditation of companies who are into the manufacture of PPEs and other goods needed to fight COVID. And we accredit them so that they can avail of business tax exemption as well as taxes and duties exemption from any of their importations. So this is under the PPE Ecosystem Initiative. Third will be the domestic preference. So we have mentioned the companies who try to answer or heed the call of the government for the local production of the needed PPEs for healthcare workers and frontliners. So now they have produced, and we need to help them also providing a ready and steady market. So we have this domestic preference initiative as well. So as mentioned earlier, this is to provide a ready and steady market for those who repurposed, particularly those who repurposed early on at the start of the pandemic. Also to support local manufacturers and maintain jobs, if not increase the jobs for the manufacturing sector, to ensure the quality and compliance with standards of health critical products supplied to our hospitals, healthcare workers, and other frontliners. And of course, again, the Bayanihan 2, which provides for the certification of non-local availability. So meaning for those products or PPEs that are locally manufactured already, there is now the support from the government, and therefore we will only allow importation of products if they are identified to be non-local available in the country. And of course, we have the strategic stockpiling. Um, we have this to ensure a ready and steady supply of health critical goods supplied to our hospitals, our health workers, and other frontliners. And of course, also to mitigate impacts of any export bans that may be imposed by source countries of health critical goods. So at any time that any of our hospitals would need these PPEs, we're assured that there is supply because of this strategic stockpiling initiative. And then, of course, in terms of vaccine development, including the clinical trials, the DTI is a member of the sub-TWG on vaccine development led by the DOST. And in there, we do bilateral cooperation with vaccine developers for the conduct of local clinical trials and possible local manufacturing. We have finalized the procedures for a facilitated approval of clinical trials, so we get to deploy the vaccines as soon as we can. And of course, we also try to meet with local pharmaceutical companies to encourage local manufacturing of vaccines in partnership with the developers. And lastly, of course, vaccine procurement, very, very important. The DTI is also a member of the sub-TWG on vaccine procurement, which is led by DBM. And in there, we try to work on the budget requirement for the vaccines purchase so that whenever the vaccines become available, we will be able to provide the funding so that we get to access whatever is available in the market. And then, of course, coordinating with the local logistics and cold chain companies for distribution and handling requirements of the vaccines. So that if, for example, we get access already from the vaccines, we will be able to already dispatch the vaccines in accordance with the handling requirements of the said vaccine, which could range from positive to negative 20 or even negative 70, as you will probably have heard from the news. So this is actually my last slide, and I think we have informed you of what we have been doing in the BOI and the DTI to help the healthcare sector against this, in the fight against COVID. So if there are anybody who would like to register with the BOI, we'll be happy to help and assist you. And Ms. Joyce Alumno has our contacts. So thank you for your attention, and have a good afternoon. Thank you.
Thank you so much to Executive Director Dichosa for that very enlightening information as to the investment opportunities that still await the healthcare industry. So now we would like to proceed with the open forum, and we would like to have all the panelists on the floor. We'd like to bring back our speakers from the Philippine Hospital Association, also from PCCI, also from Bankers Association of the Philippines, BPI, and from Board of Investments. We were able to have Yusek Vergere already from the Department of Health earlier on. So can we put all the panelists on screen, please, technical team? Thank you so much. All right, so I think we also have here on the floor Governor Obet Pagdanganan, who will later on give a synthesis and a closing remark. So, but you can already join this discussion because I think you also have several things to comment on. So thank you so much for all our speakers. First question, actually we have several slides of questions for all of you, but in the interest of time, we will just focus on the major ones. For Dr. Almora of the Philippine Hospital Association, The Department of Health has given a very comprehensive report and update as to how they are managing the COVID-19 pandemic, and also the different needs and gaps that are existing in the healthcare system right now, from now until 2035, in fact. And we were enlightened to hear that the budget has already been approved, although she did not share how much was the budget that was approved. We'll probably hear it in the news soon. My question, Dr. Almora, out of the many questions that were given to us, what do you think is, hold on, I have several questions here. Let me just choose one for you, Dr. Almora. Okay. So what do you think are the long-term strategies that the hospitals can plan for in order to address the increasing demand of care needed by COVID-19 patients, and even all the other diseases that have been confronting us, such as the NCDs that have been there. In fact, we are still leading in tuberculosis patients in Asia. We still have 1 million patients last year. And also for chronic diseases, for NCDs, the lifestyle diseases, we are number one in Asia. And then we have the COVID-19 pandemic now. So I'll just direct one question to you, Dr. Almora. How do you think, or what do you think can be the long-term strategies of our hospitals in order to manage this crisis and all the other challenges that are facing our hospitals? Thank you.
Yeah, thank you, Joy. The hospital industry is an intrinsic part of the society. So it rise and fall in accordance with the economy, with technology, with the social fabric of the society, including, politics and the core morals of the society. The long-term strategy as regards the COVID-19 is the same as a strategy for the new and emerging diseases, because we don't think this is the last of these new and emerging diseases. There will be other diseases that will be coming in the future. So I think the COVID-19 is just the start of the hospital industry to look further, deeper into preparing the hospitals for better response to the still upcoming new and emerging diseases. So we have already started increasing our ICU, our isolation rooms, our holding areas, our triads, and we will keep it at that, and we will improve on it. That is the unintended benefit that this COVID brought to us. Our hospitals were not designed really to respond to a pandemic. We designed our isolation rooms, our ICU for the occasional inpatient that has to be isolated, not in a pandemic situation. So we will continue on what we have already started to respond. And as we move on, we will ride with the technology. As the technology increases, we will adapt it, and we will improve our services.
Mm-hmm.
Thank you, Joyce.
Thank you so much, Dr. Almora. Yes, technology. We're in fact getting into the fourth industrial revolution, but there's really no way but to adapt to these changes. In fact, that was one of the things that was mentioned by Mr. George Barcelon earlier on, and so I go now to Mr. Barcelon related to that topic, and also the general sense of the economy and the business. My question for you is that what do you think, or what do you see as the a business outlook for our hospitals and the healthcare sector in the coming year 2021? A lot of people are now into budget planning. It's the end of the year, so they're planning for 2021 to 2023. Well, how do you see the healthcare sector growing next year, and how do you think will it contribute to the economy? Will it contribute, or will it take a lot of a healthcare cost and investments that this will be one of the weaknesses that we will experience in our economy for the next years. Mr.
Yeah,
Vernon?
yeah. Thank you, Joyce, for those questions. And definitely the health sectors all over the world. Okay, uh, whether it's growing, it's always growing because of the demand. Okay, wherein people do need get sick and have to cope with new ailments. So we have been growing, I think, high single digits in the Philippines. Could be even more than that. And I foresee that that will continue. Okay. Now, I cannot equate the numbers to the quality of service.
Mm,
Sometimes number is one thing, but the quality of service is another. Okay.
that's
And I after this discussion, I think there has many inputs that's been shared by the medical sectors, such as Dr. Jaime Almora and people from DOH, USEC Bergere. And we know that we cannot now not give importance to health care. Okay? And the government, especially the people in the finance, no, they have to recalibrate. Okay, giving importance to that. I think health now, per government data, is only about 5% of our GDP. Okay,
Mm.
while if you look at other developed countries, they are in the high single digits or double digits. Okay, countries like Japan, especially because of their aging population,
Mm.
is more like 13%. Okay? Um, but if you look at the future, and we have to look at our resources and our human resources. When I think of the fact that our Filipinos are medical in the medical field are all over the world. Okay, they are using our talent, and it's sometimes it behooves me why people in this sector does not leverage on the availability of the talents in the medical. And I hope going forward, both government's policy and private sectors and financial will look at it and say there's a potential not only in uplifting the service quality for the public sector, for the public, but also potential in attracting, as I mentioned, medical tourism or wellness. So these are all growth sector, okay, that can provide, jobs, and especially now with the technology, wherein we can really not only do teleconsultation, even in the side of more intricate operations, there can be done by robotics. Okay? And I have a friend who's our a Filipino who works in the States, and he was part of the team that developed the laparoscopy operations. And I can see that we're not the country's not lack of talent. We have the talent, but we do have to provide the conditions economically and politically for this sector to grow. For that matter, all sectors to grow. And I have high hopes for the medical sectors. And let's hope that the government realize that the health plays a very important role, okay, in the economy, okay? Because health is as crucial as you mentioned earlier in your speech. Health is wealth, and I also concur with what Mr. Alonso mentioned about Benjamin Franklin about being prepared. Okay, an ounce of prevention is worth a pound of cure. So I'd like to end my statement that we hope through the effort of everybody, we are able to contain. And as we move forward to 2021, we provide the kind of confidence in the public for the benefit of their livelihood. That's all. Maraming salamat po. Thank you.
Thank you, Mr. Barcelon. Yes, you mentioned about medical and wellness tourism. In fact, as you know, we're one of the proponents because we believe that the Philippines has a lot of potential as a global healthcare destination, especially for the medical professionals that you just mentioned that are present around the world. Thank you. We will have another comment related to that by the Board of Investments. But before I move to that, we would like to follow through with the question on the business potentials for our hospitals. You know that I would like to direct this question to Mr. Joel Alonso from BPI and also for Bankers Association of the Philippines. You know, Mr. Alonso, I think about 75% of our hospitals actually come from the SMEs, right, Dr. Almora? Most of them are operating like a group of a family or a group of doctors. They operate really more of as a medium or small medium enterprise. I think Dr. Almora from Kalinga Apayao, your hospital is actually owned by the family. Am I correct? Or a group of doctors?
Single proprietorship.
Oh, okay.
They
So
built it.
explains it. He is in Kalinga Apayao. He is a doctor, so he started setting up a hospital in order to cater to the needs of the people in their community. So that's the kind of ownership structure that we see in many of the hospitals, and we only have about 1,000 private hospitals across the country. So with these 1,000 hospitals, Mr. Alonso, catering to 100 million people, over 100 million, okay? So, how do you think can the banks support the small and medium scale hospitals without having too much requirements and paperwork? How do you think will you make your financial products and services accessible to them without having to go through five six or without having to sell their carabaos if there's no more, there are no more medicines to provide to their constituents or to their patients. So, is there any potential solution that you can see to this, Mr. Alonso? Thank you.
Well, as I mentioned earlier, our lending window is not closed. We're prepared to support the sector, hospitals in particular, regardless of size. But in my personal opinion, in my view, it's better to support the smaller hospitals compared to the big ticket projects that come to our table. In precisely the same manner that they serve the greater number of our population that can't afford to go to the top tier hospitals. So if we're able to provide financing for the smaller hospitals in terms of acquiring equipment on softer terms, and we're very open to that. And of course, we have to have a study also made if whatever equipment they're going to put in or whatever size the hospital or the envisioned hospital will be, will also be able to pay for itself. So as much as possible, we would not like to resort to foreclosures or repossession of equipment. We would like to help, and we have been helping. So, and if there are, well, from the government side, if there could be guarantees that could be extended to assist our borrowers, there are programs that can be implemented through the Department of Health or through local governments in terms of by extension of guarantees to help us in alleviating, let's say, alleviating payments for these borrowers of ours in times of distress, then that would be something that would be very welcome for all of us. Because we fail to see that at this time, it's a time of crisis. But as everybody among the panelists said, that this is a very underinvested sector, and we were made to realize that, especially during this time, that we are unable to cope with the crisis. So there's much opportunity also moving forward in terms of investing into these new hospitals, new clinics. But of course, it has to be a sound business proposition for us to be able to provide financing in a meaningful way.
Mm-hmm. Thank you so much, Mr. Alonso. I think for this, we really have to work also with the government especially since a lot of the receivables are really coming from PhilHealth.
Yes, it's PhilHealth.
Again, it's PhilHealth. Okay, probably we'll have another discussion or open forum with PhilHealth one of these days. Okay.
Yes.
Okay, finally, thank you, Mr. Alonso, for that. Can they reach out to you in case they need any financial help?
Well, as I said, the window is open. So we're open to suggestions, we're open to applications, but that does not mean everything will be answered by a yes. It could be a yes, or it could be a yes with qualifications, but we're always open to listen.
Okay, thank you so much. Not an advertisement really for BPI, but I think
No, not at all.
the banks, no,
Yes.
and they can always try to approach the banks. Okay, so finally, for our Board of Investments, before we proceed with our synthesis with Governor Obet Pagdanganan, Ms. Lorna Yumul of the Board of Investments, on behalf of Executive Director Dichosa, there was a question here, and it was also mentioned by Mr. Barcelona earlier on, that one of the prospects for healthcare was the medical and wellness tourism, as we were being positioned as a global healthcare destination because of the so many benefits that it could potentially bring to our country. And I have been one of the proponents of that for the last 15 years of my life. Okay, and so our question is, how does that affect the efforts made by DTI, BOI, Department of Health, and Department of Tourism? What are you doing in terms of the current and the future programs in order for this sector to recover and to be further developed? Ms. Yumul? I think you're on mute, Ms. Yumul. Yes, Ms. Lorna, can you hear us?
Yes, yes. Can you hear me?
Yes.
Okay. On the part of BOI, BOI is ensuring the continuity of tourism industry player business operation by granting the income tax holiday for the period of 4 years or 3 years. We give incentives to the tourism projects that will renovate or enhance the health and safety futures futures and processes under the Memorandum Circular 2020-004 or amendment to the general policies and specific guidelines to implement the investment priorities plan.
Okay.
The healthcare service facility kasi is one of the priority activity under our investment priorities plan that are entitled to tax incentives.
That are
including the income tax holiday and the importation of duty-free importation of capital equipment.
Because our argument there, Ms. Lorna, is that actually for medical tourism, we're not promoting the hotels. We are promoting the hospitals.
Yes,
and
it is one of the priority projects in the IPP, the medical tourism.
Okay, so what BOI did is that you incentivized, in effect, the hospitals for income tax holidays and also for duty-free importation
of capital equipment.
Okay, so Dr. Almora, that's again another thing that you can consider, because there are actually medical tourism incentives under the BOI, which covers the hospitals if they would like to expand because they are trying to market or position themselves and upgrade themselves to the global standards. Then there are incentives related to that income tax holiday and duty-free importation of equipment. Okay, so thank you so much, Ms. Lorna, for participating. I know we still have a lot of questions, but then we only have a very limited time, so we hope that we can address all the other questions to you and to Edie Dichosa and also to Mr. Ramon Lopez. Thank you so much. Okay, so at this point, we have reached the end of our program. I know there are several things, issues, concerns that came out. And I know that this is also going to be a challenging task for the next person who will do a synthesis of everything that we talked about today. To all our dear panelists, thank you so much for being here with us. And so to turn you over to the person who will do the closing remark and the challenging task of summarizing all the discussions today, one of HealthCore's advisors, He is the chairman also of the Medicines Transparency Alliance of the Philippines, the founding chairman of PITC Pharma, which actually founded the Butika ng Bayan, which is responsible for bringing in the generic medicine in the Philippines 2 decades ago, I believe. A longtime governor of Bulacan, presently national president of the Boy Scouts of the Philippines. We have Governor Obet Pagdanganan.
Thank you very much, Professor Joyce, alumno. Good afternoon, ladies and gentlemen. I'm both pleased and honored to be given this task of to be part of this great undertaking. Although I must admit to being a little bit daunted by the task to synthesize the discussions and the presentations with the limited time available and deliver the closing remarks later on. That said, let me begin by congratulating first the participants in this webinar forum, both those who've been able to join us through the webinar Zoom meeting facilities, about 500 limited to that, and the thousands both here and abroad who've been able to participate in the discussion, who also forwarded questions, some of whom were answered, and others I'm sure will be addressed later on. Let me also thank and congratulate the resource persons who did a fantastic job. Really, I enjoyed listening to them. They lent their expertise, their talents, and time to be able to discuss this very critical issue that affects all of us, the impact on hospitals of COVID-19. And let me cite some of them as I go along later on and see and discuss some of the more important points that they tackled. The powerful opening video and Joyce's remarks set a tone. And before going further, I'd like to congratulate Joyce for a job well done together with the staff of HealthCore Academy for putting this seminar together, because really this is very timely, very relevant. And the fact that top-notch speakers and participants joined in today is a manifestation of the importance of the attached to the issue that affects all of us. As I was saying in the opening video, it's so powerful that you set the tone for the webinar. As early as 2017, the rising economic tide and the increasing budget allocation for healthcare, with so-called sin taxes, spurred investments in and expansion of hospitals. Acquisitions and upgrading of facilities made headlines. Universal healthcare coverage is being implemented, although much has to be done. We'll talk more about that later on. But as you mentioned, Joyce, and as was highlighted later on by the other speakers, despite all the flurry of activities, the bed-to-population ratio in our country of 1 to 1,000 remains as one of the lowest ratios in Southeast Asia. In fact, the recent statistics from WHO show that Vietnam and Singapore had 2.5 times more than ours. And Malaysia and Thailand had twice as much. What made the situation worse was, as pointed out by Yusek Bergere later on, was that there is a tremendous disparity of distribution of these facilities. In Metro Manila, the WHO recommended level of 3 or 4 per 1,000 population is being met. Yet in far-flung areas, especially the island provinces, local government units would be so much worse, at maybe 1 for every 3, 4, 5,000 or even worse. And that has to be addressed. Meanwhile, to institute systemic reforms with emphasis on prioritizing preventive health care, the Universal Healthcare Act of 2019 was passed. The implementing rules and regulations were approved in October, and everything was set for this implementation. And then COVID-19 pandemic struck. Totally unexpected. And so all of a sudden, the ship of Philippine healthcare, which was already sailing on perilous waters, suddenly encountered an unexpected surge of giant waves. And to counter the perils, the captain of the ship and the officers and crew reacted quickly. And we know that some or other, we've been able to cope with the emergencies. And as was pointed out, as we speak here, the total case in the Philippines amounts to 417,000, with almost 8,000 deaths. Dr. Jose Almora, in his presentation, set the tone and really showed the challenges being faced by the industry, the medical industry. He said that all hospitals are experiencing significant decreases in economic activities, which is ironic because as Mr. Consing, president of the Bank of the Philippines, stated later on, and this is something that we've been talking about also, you would expect that the healthcare industry would be doing well during this period because the demand is greater. But as he pointed out, the hospital industries have been declining at about like as much as 40% negative growth. And we'll talk more about that. But as Dr. Almora said, there's been a 50 to 60% decrease in business from bed to occupancy rate, laboratory, elective procedures, and even the financial reserves of the hospitals are actually suffering. And one of the reasons here is the fear of hospitals among the people needing elective procedures and hospitalization. They shy away because they're afraid of being COVID infected. There's a problem of transport, decrease in facilities also. And therefore, altogether, as I said, from Dr. Almora's presentation, 50 to 60% brought down. And among the areas affected by this are the rice producing regions because of the rice tariffication law. Then, of course, there is the typhoon, and this aggravated the situation. Apart from that, Dr. Almora talked about the very significant delay in reimbursement by PhilHealth of their to the hospitals. And of course, it was aggravated by the PhilHealth scandal, which hopefully will be sorted out. There's also the problem of decrease in manpower among nurses, especially. And because of this, the healthcare industry, the hospitals, has to face a rather uncertain future. He also pointed out the ambiguity and over-ambitious provisions of universal healthcare law. I will talk more about that later on. Then USEC Rosette Bergere made a very good presentation stating the situation as it is now and the actions being taken by the Department of Health. She also mentioned that there are a lot of things being planned for to implement Republic Act 11494, which is really to address this, the needs of the people with the COVID pandemic and how to address other needs, health needs of our people. She also pointed out in the I'm just trying to choose here the need to really improve the bed to population ratio. She said 1.2 per 1,000 today, but in 2040 the target is to bring it up to like 2.7 beds for every 1,000 population, and level 1 will be prioritized. And Dr. Bergere also talked about the strategies to encourage private sector through tax exemptions, incentives, duty-free, importation of materials and equipment, attractive financial scheme, and this was talked about and discussed by Mr. Jovi Alonso, Mr. Consing later on, for subsidies in getting gadgets and facilities, and other incentives to be given to the private hospitals. The present emeritus of PCCI, Mr. George Barcelon, made another very interesting presentation when he talked about the need to adapt to challenges, to meet global standards, to adapt to the new paradigms. And she also talked about the comparison of the situation in the Philippines vis-a-vis our neighbors like Thailand and Vietnam. He talked about the huge allocation that are being made by these countries to improve their healthcare facilities. And then George also talked about the high out-of-pocket expenses that remain in the country, as small funds are being allocated for healthcare expenses, the out-of-pocket expenses remains at about 55%, more than 55% as a matter of fact. So the more money is being poured into healthcare, the more people have to spend out of pocket. And this is something that definitely will have to be addressed through updating of laws and to also make sure that there is a balanced approach. This means, according to George, of providing the business sector with some assistance for them to be able to provide for a healthy Filipino people. Then we heard from Mr. Cesar Consing, the VIP president, and what he said was expounded by Mr. Jovi Alonso. Again, he said, the health sector should be robust, not challenged as it is. And we talked about the more than 14% drop in their revenues and growth. Mr. Jovi Alonso, the Senior Vice President, Chief Credit Officer of BPI, talked about the need to provide the factors to be related in providing credit to the hospitals. Investor promotion, the viability of project, capital infusion by the owners, investors, collaterals offered, and specific purpose, and so forth and so on. And he also talked about the importance of making sure that people focus more on prevention rather than cure. And then we had this presentation by the Executive Director, Maria Corazon de Chosa of BPI and Ms. Humol. They talked about health-related initiatives, the accreditation for incentives, and the different measures that are being provided for by BOI to incentivize the private sector in investing more for hospital facilities. And details can be gathered from the presentations that they had. Well, the limited time, let me just talk about moving forward. What do we do then together? Well, obviously, the shape of our Philippine healthcare hospitals is now being buffeted, not just by the rising tide, by the flooding that come about and the tempest above. What we need to do is to really work together. And if you analyze from the presentation discussion, moving forward, number one, field health reimbursement should be facilitated to help the hospitals. It should be computerized so that there'll be a significant delay. Otherwise, many of these hospitals will close, especially the private hospitals. There's also the need for us to manage fear. Management of fear is important because there are a lot of people, 12 million hypertensives, 4 million diabetics, 1 million tuberculosis patients, as you said, who need care but are afraid to go to the hospitals. And so there's a need to, as was pointed out in the question and answer, isolate, have isolation facilities, mobilize the primary care units, and there should be these gatekeeping facilities and navigation for people so that we'll be able to make full use of the private hospitals for those who need care. And there's also need to, moving forward, to implement universal health care. I was happy to hear Jose Bergere saying that this should be promoted, it should be pushed through. And indeed, that will correct a lot of concerns that we have, focusing on preventive health care, reducing out-of-pocket. But we need to also address the problems about the constant financial distress that was highlighted by Dr. Almora and our banking friends. Well, there are other issues that were talked about. George Barcelon talked about the need to provide contract tracing, free vaccines, and again, the out-of-pocket expenses. Anyhow, I would close my presentation at this stage. And again, congratulate everybody for the job well done. I think it's been a very worthwhile afternoon. I enjoyed it so much, and I hope that all together we'll be able to work very hard so that we keep the ship of healthcare and hospitals safe, despite all these buffeting storms and problems and challenges, so that we'll be able to safely land ashore in our destination. On that note, I'll say mabuhay, healthcare, maraming salamat, at mabuhay kayong lahat. God bless us all. Congratulations, everybody. Great job. Learn a lot.
Now we can address each other properly. Knight Governor Obet and Princess Joyce.
It's okay, George. Yeah, thank
Thank you.
you.
Okay.
Thank
Yeah.
you very much.
Thank you, Dr. Arme. Bye-bye.
You,
Thank
Governor.
you. Thank you.
POC, Director Yumol, thank you. Okay,
Thank
bye-bye.
you.
Yeah.
Thank you.
Thank you. Thank you very much again to all our panelists, to Governor Obet of one of our HealthCore advisors, and to all of you, our healthcare workers and frontliners, our heartfelt gratitude and our salute for your untiring efforts in our battle against COVID-19. In HealthCore, we continue to come up with workshops and programs like this in order to assist you, such as the infection prevention and control workshop that we are holding on 25 to 27 November next week, which is actually the third batch already. If you haven't registered, you can visit our website www.health-core.academy so that you can register for the infection prevention and control workshop, which is actually a 3-day workshop. So thank you so much. We know that the battle is not yet over, but we will try our best to equip you and stand by you during these difficult times so that all of us will rise above these huge waves that continue to confront us. That concludes our first online forum. Thank you very much.